This is a clinical skills station for the Hand Diploma examination. Come through.
Hi, good morning.
Hello. Take a seat. So this is a clinical skills station. What we have here is we have some radiographs. I'd like you to have a look at them. This is a patient who is 60 years old. She's a housewife and she's got discomfort in the base of her thumb, and it's worse with twisting movements. She's been troubled for 2 years and the discomfort is getting worse despite using regular analgesics. What do you think is the diagnosis?
So the diagnosis sounds like it's basal thumb arthritis, or first Cmc arthritis. Looking at these radiographs, they look like PA radiographs of the base of thumb joint. I can see large osteophyte, sclerosis, loss of joint space, and some cysts affecting the first CMCJ, and as well as sclerosis and quite bad arthritis affecting the scaphotrapezial joint as well. So it is pantrapezial arthritis, I'd say Eaton grade 4, and there's some dorsal subluxation of the CMC joint, and there's also some hyperextension at the Mcpj joint of the thumb.
What treatment options do you think there are for this?
Treatment options, as always, we start with some conservative management, and the first options are oral non-steroidal anti-inflammatory drugs, or even topical splinting and hand therapy, and a trial of this might improve symptoms.
What sort of splints would you provide for this condition?
Just a thumb spiker, and it could be used at various periods at night sometimes. I would say for arthritis at this level, grade 4, splits and NSAIDs might not work as well, especially since she's had worsening symptoms and she's tried analgesia according to the history. The next step up in intervention is steroid injections, and with steroid injections, I'd say they work better for grade 2 to grade 3 and mild arthritis when the main predominant factor is synovitis.
So you've just told me about Eaton grade 4. Can you tell me about stage 1, 2 and 3?
So stage 1, there's predominantly some synovitis and some loosening of the ligaments, and you get some joint space widening, and there's no osteophyte formation or anything like that. In stage 2, there's some osteophytes, but they're less than 2 millimeters, and there's some joint space narrowing. In stage 3, there's large osteophytes, so more than 2 millimeters, and significant joint space narrowing. And then stage 4, you get pantrapezial arthritis like this.
So you don't think this patient would be a candidate for a steroid injection?
If she was a poor surgical candidate, I'd say steroid injection is an option. There's a paper by Swindles in 2010 which shows that even grade 4 arthritis, they did have good effect from steroid injection, although the numbers were quite small. In fact, they showed they had better relief from pain compared to other stages, but most other literature would say that grade 2 to 3 would be more appropriate for steroid injections.
So in this particular case, you decide to offer a surgical solution for this. What treatment options would you provide?
Treatment options surgically for this, I'd say the most practical treatment would be a trapeziectomy, and with ligament reconstruction, and we probably have to address the Mcpj joint hyperextension at the same time.
So just to break that down, what do you mean by ligament reconstruction, and why would you do that?
So a trapeziectomy alone can be sufficient based on the current evidence. Some people would elect to use a tendon interposition or ligament reconstruction or both, and that can be done using an FCR tendon or an APL tendon, or even a palmaris graft just rolled up and used as an interposition. And this is usually used to stabilize the thumb metacarpal and prevents future subsidence of the metacarpal and prevent impingement on the scaphoid. Also just during pinch and grip procedures just to stabilize the thumb.
You mentioned that you'd have to address the thumb hyperextension, the MCPJ. What would you do for that?
So the thumb MCPJ, I would say it depends on the degree of hyperextension of the thumb. I get the patient to actually do pinch maneuvers and grip maneuvers to see how much hyperextension, how unstable the thumb MCP is. Also, if there's arthritis in the thumb. So If there's just about 10 degrees hyperextension, we could just stabilize it with a K-wire and see how things go with the trapeziectomy as well. If there's a bit more hyperextension, then I would say she would need a volar capsulodesis or even a sesamoidesis. With more than 30 to 40 degrees hyperextension, and if there's arthritis as well, then I'd say an MCP fusion would be probably the best option.
So why does the McPj hyperextend like this?
So when you have arthritis in the base of the thumb, and your plantar trapezial arthritis is like this as well, you can see the Cmc joint subluxus dorsally, and then you get adduction, adduction of the thumb metacarpal. So in order to compensate for that, there's a Z deformity and the McPj joint hyperextend to make up for the adduction.
Okay.
In order to get the span that you need.
So you've suggested that a trapeziectomy with a ligament reconstructive procedure is your preferred option. We'll come on to that in a moment. Are you aware of any other procedures that are offered for this condition?
Yes, so you could do an arthroplasty for this condition. You could do just tendon into position, trapeziectomy alone, tendon into position. You could do double into position. You could do an arthroplasty, and you could
Okay, that's absolutely fine. Right. What I'd like you to do, this is a patient who you're going to be offering a trapeziectomy on. What I'd like you to do is just talk to them and explain what you're going to do and what those risks of surgery are going to be and what they can expect in the post-operative course.
And so we're going to perform a trapeziectomy on you, where we're going to remove the bone that the base of your thumb is resting on. Okay, it will involve a scar just going across the back of your thumb here, and the section down. You do have tendons and nerves in the area which are at risk of getting damaged. We're obviously very careful when we do it, but if there is damage to that, we do repair it, and we can get onto that if that's a problem. We go down, we take the bone out, and what we do is we use a bit of tendon just to stabilize everything for you. Post-operatively, what would happen is your wound would be closed with absorbable sutures, and based on this, we will check your wound in a week's time. You will also have a cast on. We leave this cast on, especially if we use a tendon to stabilize the joint. We leave it on for about 4 weeks at least. We then take the cast off and mobilize you with some hand therapy and give you some exercises to do. You will feel the pain actually probably get worse over the first 48 to 72 hours, and then pain will gradually get better, but you find your arthritic pain improve over the next few weeks, but you get post-operative pain, which can actually take a long time to get better, and you'll find your strength and your pain improving, your strength improving. It will be quite protracted. It can be up to 3 to 6 months before you actually see good improvement. Your strength will continue to improve up to about a year.
Can I ask you to just now have a look at where you would make your incision? Can you just mark the relative or relevant surface markings of those structures you've discussed? And,
so I would prefer to do a dorsal radial incision, and the first thing I would do is mark out the Cmc joint. So we've got thumb metacarpal there, and mark out the Cmc joint where I think it is. And then we've got some relevant structures to watch out for. So you have the superficial radial nerve, which would course along the radial side, and then it splits into a branch going to the thumb, and you've got a branch going to the index finger as well, so that will be in the way. We also have the first dorsal compartment, so the APL and the EPL tendons that go across there.
Do you mean EPL?
APL and EPB tendons here, and the EPL tendon there. And then you have your radial artery, which comes on the volar side here, and it courses on a volar to dorsal direction across the snuff box again, and goes through the two heads of the adductor pollicis. And there's also a little volar carpal branch which goes there. The incision I would make is on the just parallel to the first dorsal compartment, about 4.5 centimeters or so across the Cmc joint, going down in a straight line.
And you mentioned that you do an LRTI. What's your preferred tendon for your ligament reconstruction?
So LRTI is usually done with the FCR. You can use an APL as well.
Would you show me where you make your incisions for the FCR harvest?
So for the FCR harvest, if I was doing an FCR, I might actually use a Wagner incision, and then I would do an incision between the glabrous and non-glabrous skin, stopping at on the border of the FCR. And the FCR tendon, I'd get the patient to extend the wrist, and you can mark the FCR tendon down there. And then I'd do a transverse incision there. If I was doing a dorsal incision and not there, I'd do an extra transverse incision there, about 1 centimetre, and then at the muscular-tendinous junction, another transverse incision. Use a tendon stripper or a tendon passer to harvest half the tendon. I would take the ulnar half of the tendon and then feed it across. I do prefer to use the APL as a suspensionoplasty as opposed to a ligament reconstruction and interposition nowadays.
Okay, thank you. So if you've undertaken your surgical procedure, you've done a trapezium excision and an APL suspensoplasty, the patient's been in plaster, come out of plaster, starting to rehabilitate, and maybe 6 months down the line they're starting to get pain again at the site of surgery. What are you thinking of in terms of the cause of this pain?
So the cause of pain after a trapeziectomy could be, during the operation ideally I would have inspected the base of the second metacarpal and the trapezoid joint and the scaphoid joint, the scaphotrapezial joint as well. So I would say persistent pain would be an unaddressed scaphotrapezial arthritis. That could be one of the causes of pain. Another cause of pain could be injury to the superficial branch of the radial nerve. Could be unaddressed MCP hyperextension, so you can get late collapse of the MCP. That could be a cause of pain.
How would you deal with that?
In that case, if it's a late collapse of the MCP, you then have to address the MCP joint and go through the options that I talked about.
In a simple trapeziectomy and the patient comes back 3 months after surgery, they've been out of the splint and they're starting to complain of pain at the site of surgery. Are there any conditions that can cause this? What would you be thinking about?
So the first thing I'd be thinking about is actual Aythogenic injury, so injury to the superficial branch of the radial nerve during the procedure. That could be a cause of pain. The other cause of pain could be unaddressed arthritis, so pantrapezial arthritis, so arthritis at the scaphotrapezoid joint, the ST joint that was present, and you just took the trapezium out. That arthritis could still cause persisting pain. Another cause of pain would be hyperextension at the MCP joint that wasn't addressed. You can get late painful collapse and instability of this joint. Other causes of pain can be things like complex regional pain syndrome and damage to other structures in the area.
So just to ask you about a couple of those, you mentioned about residual pain at the scaphotrapezoidal articulation. So how would you address that if you felt that was the feature of the pain postoperatively?
If I noticed some arthritis there during the operation, you could do a distal pole scaphoid excision, or you could do a proper 1/3 of trapezoid excision as well. If it was post-operatively and I found that was a problem and it was something that needed further surgery, we can then go in and actually excise the scaphotrapezial joint and then use tendon interposition.
Okay. What about for the Mcpj hyperextension, if you felt that was the source of the pain? What are the treatment options?
So for Mcpj hyperextension, if that was the source of the pain, then it again depends on the degree of instability and pain and hyperextension at the MCP. For just mild hyperextension and volar capsulodesis would be a treatment option. And for more severe ones with arthritic MCP joints as well, I'd say a fusion in about 20-25 degrees would be my preferred option.
And so that will give you a scenario that the same patient has had a simple trapeziectomy and they've been fine for 3 years, but they then started to present with pain 3 years after a simple trapeziectomy. What conditions might you consider? You've already mentioned about migration. What do you think is underlying that problem?
So there's a problem with migration, subsidence of the metacarpal and impingement on the scaphoid, but I'm not sure of the clinical relevance of that. If There is also a strong stabilizer of the scaphoid trapezoidal ligament, and I think there have been reports in literature that you can get some late flexion and dizzy deformities and carpal instability in the wrist after a trapeziectomy.
What about if the patient's just on gripping is getting symptomatic subluxation at the site of your previous excision?
So if it was a simple trapeziectomy, so there's no interposition or ligament reconstruction performed, it's just subluxation of the joint, so it needs addressing really its instability at the Cmc.
And what sort of options have you got to treat instability, late instability there?
In that case, then I would do a ligament reconstruction or tendon interposition.
And could you talk me through that ligament reconstruction? What would you use in that scenario? So
in that scenario, I would use the flexor carpi radialis tendon, FCR tendon, harvest the tendon volarly, take the ulnar half of the tendon actually twists 180 degrees, and then you get a more one that's closer to the actual volar ligament, and then drill a hole through the metacarpal, feed it through, and then suture it through the metacarpal into the APL tendon as well. Wind it around the FCR and APL tendon.
Okay, thank you very much.
Thank you.
And this is about assessing the candidate's ability to come up with a diagnosis, formulate a management plan, counsel a patient, and then discuss some of the complications. And it's a structured assessment. So there are various different parts of the assessment. So here you can see diagnosis and treatment, the operative procedure and discussion of risks, dealing with complications, and then those surgical options for those complications. And there's a very structured process of assessment. So we need to know about the core basic science knowledge and the remarks for that, clinical knowledge, and then of course as we move through this marking scheme, it allows us to assess communication skills and also bring in evidence from the literature to enhance and show higher order thinking. Higher order thinking is really assessed in trying to determine the complications and the investigation and management of pain after trapeziectomy, and then coming up with some management strategies and discussing how to do those management strategies. Clearly the candidate who's excelling, as in this case, will move smoothly from step to step in sequence with minimal prompting from the examiner. But the examiner's role is to make sure that all of the key questions and elements are examined to allow the candidate to perform well. And that's why the examiner will try and move on the candidate in case the time is running short, so that they can actually be assessed on every individual area. So this overall marking scheme is 32 points and a pass mark is 20, and this would be a sign of an excellent candidate with no concerns at all across the board. The important thing to remember is when you're doing one of these exams is the examiner is not there to give you feedback, to prompt and guide you, but they will push you for knowledge if you can earn more points, and they'll also move you on to other sections. So sometimes the candidate may feel they've not had the opportunity to say everything they know, but it may be they're not in a point winning position and that they need to move on to other sections. And so don't be too disheartened if you don't get feedback from the examiner. That's not what they're there to do. Don't feel too disheartened if you've not been able to tell them everything you know about a topic. You won't earn all the points for that section. So the examiner is there and they're very experienced to guide you through the process. And just because you feel you've been given a hard time and your knowledge has been pushed doesn't mean you're not doing extremely well. The examiner will push the best candidates to try and work out the exact margins of their knowledge and how much they know.